Uh-oh. You started the podcast.
Okay, Bassam, I'm going to go ahead and make you the presenter and we're going to get started.
Thank you.
Hello, everyone. This is Mallory Caldarella from Samba's management team, and I will be your host for tonight's webinar. Thank you for joining us this evening to discuss COVID-19 from A to Z. Let's start with Samba's legal disclaimer, which you will see shared on the screen. While you all read through this, I want to mention a few quick housekeeping notes before I pass things over to Samba's president and tonight's moderator. Each of you have a control panel that can be found in the upper right hand of your computer screen. Please note that this webinar is in listen-only mode. We do encourage you to submit your questions in the question box throughout the duration of the webinar. You can type in a question or comment and submit it at any time during the presentation. We will have time for Q&A at the end of the presentation. If you experience any technical difficulties throughout the webinar, please submit a chat within the chat box. Our staff will monitor this and assist when necessary. I would now like to hand things over to Samba's president, Bassam Abdulmalik, so that he can introduce us to the speakers tonight.
Thanks, Mallory. I appreciate it. For those of you who do not know me, my name is Bassam Abdulmalik, anesthesiologist at Cleveland Clinic. I'm Samba president. As I'm sure you have heard, Samba 2020 has shifted to a virtual experience. So please visit our website to register now and join us June 6th and 7th online and from the comfort of your home. Also, I want to mention next week's webinar topic. As you notice that today's topic kind of brings us to prepare us for the next week's topic. As you all know, the whole nation is going through how should we restart the country, how should we go back to do elective surgery in our ASCs and so forth. So we thought of issuing a statement that all of you have received it in the mail. For those who are not Samba members, can go to our website, you'll see the statement that was issued today. And we put together this webinar series, and today number 3 and next week number 4 are dedicated to that topic. So as tonight we're gonna get an update on the COVID-19, what is the latest on that. Next week we're gonna hear from our speakers on roadmap to reopening your closed ASC and resuming elective surgery. If you are not a Samba member, I would encourage you to join us. We would love to have you in our society. As you see, there are many Samba member benefits. Please visit our website to explore those. And this webinar is one of them, and there's more to come. Also, Samba leadership has established an online resource page to help our colleagues in dealing with COVID-19. This area is open access, not limited to just Samba members, so please share freely and widely, and I hope you will find it helpful to you. With that, I will move on to introduce our speakers. First, I would like to thank both of them for agreeing to help us out with this webinar. They are not Samba members, but they are friends and colleagues and experts in their areas, and I really appreciate them agreeing to help us out. We will start with Dr. Sharif Mossad. Dr. Mossad is Professor of Medicine at Cleveland Clinic Lerner College of Medicine of Case Western Reserve University. His section of transplant, infectious disease within the Respiratory Institute at Cleveland Clinic. Also, we have George Williams, who is Associate Professor and Vice Chair for Critical Care Medicine, Department of Anesthesiology. He's also the Medical Co-Director of Surgical and Intensive Care Unit at Lyndon B. Johnson General Hospital. He also served as the chair of the American Society of Anesthesiologists Committee on Critical Care Medicine. Without any further ado, I would like to ask Sharif to start with his presentation, please. Sharif.
Thank you, Bassam. It's my privilege to be here to share with you what I know about this pandemic. For disclosure, I'm on the Cleveland Clinic's Research Prioritization Committee for this disease. Over the last few months, we've had an explosion of information, and if you see from this graph, over 5,000 publications in PubMed since January. So as we have outlined, we'll talk about the virus, the pathogenesis, comparing it to other outbreaks and some other infections, epidemiology, clinical presentation, diagnosis, prevention, and our hope for recovery. So let's meet the enemy. So this is one of 7 coronaviruses, very closely resembling to the MERS-CoV virus and the SARS-CoV virus from a number of years ago. There are several other coronaviruses that infect humans and animals. So this virus invades the body by attaching to the angiotensin converting enzyme 2 on the respiratory and gastrointestinal epithelium. It also requires a co-receptor, which just has numbers, TMPRSS2, to prime this attachment. And if we compare this to MERS and to SARS from 2002 and MERS from 2012, the pandemic duration for SARS was about 8 months. MERS has been sporadic since that time, so we're still seeing some cases, but not a lot. And so far with COVID-19, it's 4.5 months. SARS and COVID-19 started in China and MERS started in Saudi Arabia. Most of them have animal hosts. In fact, all of them have bats, SARS and bats. Fewer countries with SARS and MERS, and much more countries, and this as of April 17th when I prepared these slides, with 210 countries affected with COVID and over 2.2 million and 6.7% deaths worldwide. If I make it simpler for myself, SARS took 8 months to infect 8,000 people and kill 800 like a lion. MERS was like a cobra snake, took 12 months to infect 100 and kill 30 of them. And COVID is like a leopard. So far, 4.5 months, infected 2.2 million and killed over 150,000. So how contagious is this? And we've been hearing about this reproductive number, the R0, which is basically how many people can one person transmit the infection to surrounding susceptible population. And the best place for that transmission would be in the household. So for SARS-CoV, that number is 2 to 3. That was known from the cruise ships because it was a closed environment. And the subsequent studies showed a 10% household attack rate. For influenza, it's 1.2, so it's lower. And it was variable in terms of the household attack rate, varies from 1 to 38% in different studies. Truly aerosolized infections and airborne infections like measles and varicella and tuberculosis, much higher reproductive number, 12, 10, and 10, and much higher household attack rates, 90, 85, and 50%. So if we go back and look at the global epidemiology, currently the hotspots are in Europe and the United States. The epidemic in China is receding, and these are the numbers per 5,000, more than 5,000 people per million. And if you look at the total number of cases, it really took off sort of globally towards the middle of March, and total deaths a little bit later after that. And if we look at the countries as of a couple of days ago, affected, as you see at the top there, United States, and at the bottom, Japan, South Korea, and China, where it started, it's leveling off. And closer to home, the US epidemiology, the hotspots are currently in the New York area, and Florida, Texas, California, Seattle. These are the areas with more than 10,000 cases or more. And if we think of hospitalizations, overall hospitalizations, as you see here in red, per 100,000 population is about 20. Much higher of these populations would be people 65 and above, and obviously much lower in people who are 0 to 4 or 5 to 17 years old. And of people who get hospitalized, the deaths are clearly higher in people above the age of 65, up to 40% people 85 or older, but also more than 10% in people above 45 to 54 and upwards. This might be maybe some reason for hope. The number of deaths over time since late February have dipped a little bit in the last week or so. So peaked at 5,000 towards the early April. And if you focus on healthcare settings, so what constitutes a close contact in a healthcare setting? So that's within 6 feet of a person infected for a prolonged period of time, and that is variable, at least 10 minutes. And then having unprotected direct contact with secretions without any protection. And the exposures in healthcare settings are either high, medium, or low risk. So for high and medium, the prolonged close contact without wearing a mask while the healthcare provider is exposed. And the highest risk would be in a room with an aerosol generating procedure with the healthcare provider not protected. The medium risk, where the healthcare provider is wearing some protection, but not the highest protection, the N95, and then the low risk is anything below that. So these are the categories, the high, medium, and low risk. So one example of these in California, earlier in epidemic, 121 people were exposed to someone who came to the ER, and 14 of these were high risk, 80 were medium, and 27 were low risk. Only a third of these were symptomatic, and when they tested these, only 7% were positive. These 3 people too were high risk. One was administering BiPAP, and one was also intubation, and one was medium risk with no aerosol generating procedure. And if you look at all US healthcare workers where they were exposed from a recent MMWR, about half were exposed in healthcare, and the rest are either in household or in the community or some overlap. And there were no data in this report about the specialties of healthcare workers. From China, of 23 healthcare workers who unfortunately died from COVID-19, 13 were physicians, 5 were community practice physicians or private clinics, 3 were Chinese medicine, 2 were internal medicine, 2 were respiratory medicine, 1 was a gastroenterologist, 8 were surgeons, 3 of them were ophthalmologists, and actually the whistleblower was an ophthalmologist, and 1 was an EKG technician, and 1 was a nurse, and there were no anesthesiologists listed in this report. This recent BMJ report looked at all the predictive models that we have for diagnosis, prognosis, and mortality, and there were 31 of these published so far, 13 for hospitalization, 18 for diagnosis, and 10 for prognosis. And unfortunately, they were all poorly done, poorly reported, had some bias with some performance optimism, so we really can't rely on these. How stable is this virus? You've heard this information before, but it's good to reinforce it. So on plastic, about 3 days, and stainless steel about 2 days, cardboard 1 day, and copper about 4 hours. And we don't have any data on cloth, so we don't know about our clothes, our scrubs, or masks, how long these would last. The clinical presentation has been widely publicized. The majority are mild or asymptomatic, 15% moderate, and 5 severe. The most important is if it's a flu-like illness with fever, cough, and trouble breathing, and trouble breathing it could actually set for about 4 to 8 days from the onset of illness. Up to 20% actually have some gastrointestinal symptoms. And that issue about losing sense of smell and taste, some reports about 60%, but this is not a peer-reviewed paper. And then ARDS, obviously, we'll hear more about that in the next presentation. some neurological manifestations, and it's unclear whether these are direct from the virus or just from being in the ICU, and hypercoagulable state with people having PEs and DVTs. Something else that I came across was the collateral damage of this disease. So a cardiologist reported this recently. There was a 38% drop in the average ST elevation MI activations between the beginning of this epidemic and currently. And if you see on the left side of the screen in blue, 2019, and in dark red, 2020, clearly a drop. So what about that issue about asymptomatic or pre-symptomatic transmission? So in Singapore, the people that came from China and were tested as soon as they came, 1% of these were tested positive who were asymptomatic, and in Germany, about 1.8%. And in Singapore, they did excellent contact tracing for about a month and a half. They had 243 cases. 157 of these were locally acquired, so they were not infected when they came in. And about 6.4% of these constituted transmission from an asymptomatic or pre-symptomatic person in the community in Singapore, without having any other exposure to someone else who was clearly infected. This was from the United States, from I believe Arizona, and this was a person who had a mild illness, went to the ER, was tested about a couple of days after the onset of his mild cough. His PCR test remained positive, but the viral load decreased over time. But as of 18 days, it was still positive, but negative after that. And his symptoms sort of overlapped that, but actually his cough resolved a couple of days before his PCR became negative. There were 16 contacts to that person. 5 were medium risk and were not tested. And the 11 high risk people, one of them was, quote, intimate contact, and I'm not going to comment on that, but 2 were household, 3 were healthcare, and 5 were ride shares in cars. And all these were tested, 35 specimens, up 1 to 7 tests per person, and they were all negative. So how are we diagnosing this? We're learning something new. This is, we're using our tests. It has to be targeted to where are we using the test. Is it screening? Is it during the incubation? Is it for diagnosing active disease? Is it for removing someone from isolation, or for monitoring shedding and bringing them back to work? So these are different reasons for testing. And this excellent paper from the Annals of Internal Medicine really sums it up. So in the middle of the screen, in the red box, really the molecular test, the PCR test, is the way to go at this time for diagnosing active disease. Some of these are point of care tests and maybe a little bit less sensitive, but they're still molecular tests. Antigen detection is not developed, and serology is still not for prime time. So we cannot use these for anything at this point. CAT scan has been touted as a diagnostic modality, and you see here the classic presentation with the bilateral ground glass opacities, and almost 100% of people who tested positive by PCR, these were bilateral, mostly posterior ground glass opacities, and these subsegmental vessel enlargement were reminiscent of probably subsegmental pulmonary emboli. So in people who were PCR positive, the CT sensitivity and negative predictive value were high, with an average accuracy of 72%, but the specificity and the positive predictive value were low. And in terms of labs, the majority of people who were in ICUs were lymphocytic, had high LDH, high LFTs. Many of them had renal insufficiency and required dialysis, had D-dimers and had signs of coagulopathy, and had high CRP and ferritin, I think is not on the slide as well. This virus looks like it likes to cohabitate. So this was done just in the last month or so, and 6.9% also had rhinovirus. Some also had respiratory syncytial virus, some other coronaviruses, and the smattering of other viruses. And in total, about 20% had other respiratory viruses. Now, in terms of prevention, things that you've heard about: hand washing, social distancing, coughing or coughs and sneezes, masking, and the cloth masks are considered an extension of cough etiquette. Disinfecting surfaces, and I do not think this is a main method of prevention, but some, and staying home while we're sick obviously is very important. And then beware unsubstantiated claims of different things that you might hear online or otherwise that could prevent. These are really the ones that I see on the slide, are the ones that I know are tested and true. The NIH trial for the vaccine started on March 16th. It's a messenger RNA vaccine. It's a phase 1 clinical trial, basically for safety. Healthy volunteers between the ages of 18 and 45 from Seattle were included. It's going to take 6 weeks. So in the next couple of weeks, it will end, that we'll know something about the safety. But for availability for the public, it takes about a year to longer to get some results of efficacy. The treatment is mainly supportive for mild disease as for moderate disease. There are currently no approved FDA medications or biological products for treatment. And the recently published Infectious Disease Society of America guidelines for treatment and management basically mention everything that you see on the slide in the context of clinical trials. And in fact, some of them are only in the context of clinical trials, including the one with addition of azithromycin or the lopinavir, ritonavir, or tocilizumab. Their recommendation was against the use of corticosteroids for anyone with pneumonia, but to consider it for ARDS, again in the context of clinical trial. And then mentioned under other, a smattering of other things that had very weak recommendations, so some other antiretrovirals. Convalescent serum for prophylaxis is a study just opened, so we have no information. Ribavirin, basically no. Oseltamivir, basically no. IVIG, there are no studies, and the studies might come from the plasma transmission. Remdesivir is the antiviral that we know that has activity and had activity against Ebola, MERS, and SARS-CoV-1. Currently, the compassionate use study is underway, and one publication in New England Journal of Medicine showed an improvement about 2/3, 13% mortality and good toxicity, but still this is to be known. And should we stop non-steroidals? The answer currently is no. And should we start ACEs and ARBs? The answer is no. Now, I want to end up with a reason for hope. So if you see up top here, the doubling time in the last week or so is about 14 days, which is how it started. In the middle of the slide, you see 6 or 7 days. So I think we're making some progress in terms of slowing down of this pandemic. And this is our quote of probably our current new reality. We are currently under phase 1 or lockdown somewhere here. Hopefully we're getting soon to the bounce back, and then we'll meet the new reality where there'll be some COVID going around, but not as bad as phase 1. And how can we bounce back, and what do we need to do that? You'll probably hear more about this next week, but we need widespread testing, cohorting of infected patients, restructuring of your waiting rooms, as was mentioned in your announcement today. I read it. Risk stratification to catch up on procedures, which one can be done safely, again for next week. We have to continue some physical distancing, support of our employees, and make sure that we have enough PPEs. And then once the effective treatment is published and the vaccine obviously is published, is available, then we'll be able to really get into the phase 4 where the new normal. So in summary, I realize that this is moving at the speed of light. What I told you is probably outdated just based on the fact that I prepared it in the last 3 days. We are just beginning to understand the virology and the epidemiology. It's mostly human-to-human droplet infection. The proportion of asymptomatic or pre-symptomatic transmission is currently unclear, but probably not high. Prevention is mostly by behavioral measures. The vaccine development is underway. Treatment is currently supportive and multiple clinical trials are underway. Hopefully we'll have some answers in the next few months. And we have reason for hope and we have a road for recovery. I thank you for your attention and I will take questions probably towards the end.
Thank you very much. I appreciate the opportunity to present with such a distinguished panel. I would definitely want to thank Dr. Masad for that fantastic presentation, and also to President Abdelmalek for the privilege of coming to share with the society today. I really want to just get a chance to talk about COVID-19 considerations for ambulatory care. And in order to effectively do that, we'll have to understand some of the background information that goes into the management of these patients in their critical care setting. I don't have any relevant financial disclosures, and so we'll get right to it. I think that Dr. Masad's presentation had a really great opportunity to go over this, but there's a couple of things that are very important to point out as to how we manage these patients. Transmission's already been reviewed very nicely, and particularly that there's a spike protein that has incredible morphology that allows it to bind to ACE2 receptors on multiple species. But I think what's also important to point out in this particular setting is that not only does the ACE2 receptor bind to multiple species, but also binds to multiple types of tissue in the human body. This diagram here is published by Rotham et al. In February 2020 demonstrates, of course, the lungs are a very, very important part of the pathophysiology of COVID-19 infection. However, there are also other organs affected, such as the heart, the esophagus, the ileum, and the bladder. And we also see patterns of disease in the liver, the kidney, the stomach, and the nasal mucosa. And so really the high relative receptor affinity of this spike protein really interacts with not only alveolar type 2 pneumocytes, which are the pneumocytes that are responsible for immune function as well as transformation into type 1 pneumocytes, but also stratified epithelial cells, which you can see, for example, in the nasal mucosa or in the face. And of course, the absorptive enterocytes there as well. What this really effectively means is that when we're dealing with or treating a patient with COVID-19 related illness, we're effectively treating a multi-system disease. Most of the media emphasis has gone on ventilation, and I will be discussing that some today, but it's important to recognize we're dealing with many types of end organ dysfunction that we can expect. When we look at this, this report that came out of Wuhan, China, we see that there's a pretty broad diversity of presentations when it comes to whether or not the patient is discharged, whether they die. But the sepsis tended to occur essentially on the same day, about 9 days into the hospital stay. And ARDS came just before 2 weeks, regardless of the outcome of the patient. They all had fever for the first 12 days. They all had cough for most of their time of illness, and they all ended up getting dyspnea when they were sick enough to be in the hospital. But we must remember about 80% of patients don't make it to the hospital because they are well enough to stay at home. The 20% that do get to the hospital are the ones we're referring to here. Furthermore, we'll see that we're looking at systemic corticosteroids commonly administered just around the beginning of week number 2. And this has pretty important implications because when we see a patient that actually ends up progressing to having a complicated course, at the end of 2 weeks, we start seeing acute cardiac injury, acute kidney injury. And when we say acute cardiac injury, that's a cardiac myositis, which occurs in about 6% of patients. And when we say acute kidney injury, we're referring to essentially acute renal failure that may require dialysis, which occurs in about 15% of patients. Furthermore, there are also secondary superinfections that we tend to see, and these infections will be bacterial pneumonia on top of the existing pneumonia. This was not specifically noted in the survivor column here, but we definitely do see it there. One thing that I think is very important for us to point out, which will be quite effective data point for us to consider very shortly, is that all these patients are essentially in the ICU on average nearly 3 weeks. So 3 weeks of ICU stay is an incredibly long stay and is associated with a great deal of comorbidities and potential complications. And that has ramifications for long-term care. When we look at the management of these patients from an ARDS standpoint, prone positioning has become an extremely important part of management. We thought it was going to be important before these patients got to the United States. It is clearly extremely important. And this image is captured from the New England Journal of Medicine face sheet demonstrating the results of the PROCEVA trial, a trial that took place in France with nearly 240 patients randomized to receiving prone position and ARDS versus not receiving prone position. It's important to recognize that baseline mortality for prone positioning is between 40 and 60%. In this study, mortality at baseline was 33%, but importantly, mortality reduced down to 16%. And this was an incredible result and really changed the way we treat patients with ARDS nationwide. Furthermore, we've certainly employed this in the COVID-19 population. And the logistics can be very interesting because, importantly, we're not only doing prone positioning in patients that have been intubated and sedated, but we are actually doing prone positioning in patients before they're intubated, while they're on nasal cannula oxygen, while they're in their room. So prone positioning is going to be a very, very big component of what we actually consider as part of the management strategy for these patients. Now, there are risks when you have a patient that has multiple lines, that's intubated. All those sorts of things really can certainly lead to injury whenever this prone positioning is taking place. Sometimes people use rotabeds, like the one who is pictured here from the ICU that I was staffing when I was taking care of this particular patient. But there's lots of potential things to see there. When we look at the range of hypoxia therapies, though, there's a lot of different, there's a big wide pair that we should consider. We always want to reduce ventilator-induced lung injury because we don't know what the long-term ramifications of this are. So, for example, while we can say that we give high PEEP, aggressive plateaus and things of that nature, we're not certain as to what the end functionality is going to be 6 months after discharge, 1 year after discharge. We'll talk about that in a few minutes. We have done a lot of PEEP on these patients. PEEP has been calibrated to the 2 different types of disease we see. We see highly compliant lungs that really don't require much PEEP and seem surprisingly easy to ventilate. And then we have low compliance lungs, which require a lot of PEEP, which are challenging to ventilate. These patients end up requiring quite a few recruitment maneuvers along with the PEEP, which is a very big part of our strategy, along with prone positioning. But remember, prone positioning requires pretty deep sedation, and that deep sedation has substantial long-term ramifications, particularly when we use neuromuscular blockade. Nitric oxide is associated to a degree, at least theoretically, with carbon monoxide injury and things of that nature, but methemoglobinemia and things of that nature, not carbon monoxide, but methemoglobinemia. However, when we're looking at nitric oxide, we use it very often in order to improve pulmonary vasodilatation. So when someone has used nitric oxide and we have, for example, let's say some signs of organ dysfunction, the most common culprit being renal disease, this is something we can see long-term after nitric oxide. And finally, when we look at extracorporeal membrane oxygenation, or ECMO, we have VV or VA ECMO, and the long-term consequences of that remain not very clear because when we have historically used ECMO, these patients have had extremely high mortality is expected to go into that particular modality. Now we use ECMO a lot more commonly. There's a lot newer outcome studies utilizing this, including in ARDS. Just one quick thing to make sure review in terms of prone positioning. Remember that when we look at our physiology, we have the anterior component of the thorax, which gets most of the ventilation because it's high compliance area, whereas the posterior portion or dorsal alveoli are collapsed because of the low compliance area. We're designed to have the chest expand and the rib cage move forward in the ventral area compared to the dorsal area. But similarly, with all that sedation we just talked about giving, we end up getting the same pattern of inhibited hypoxic pulmonary vasoconstriction that we see in the operating room. And so the dorsal lung gets a lot of blood flow, ventral lung gets a lot of ventilation. When we turn the patient prone, we flip this on his head, no pun intended, to where we actually get more ventilation for the dorsal alveolus, i.e. less collapse. And that lung actually ends up getting a normal amount of blood flow instead of an extremely high amount of blood flow, which helps resolve shunting in both the conscious and unconscious patient. So when we look at critical care management issues for these patients and summarizing this and how this affects our ambulatory patient population, it's going to require a lot of sedation to do the things I just described. These patients are going to be on pretty high doses of propofol for quite some time. In many instances, these patients are not able to tolerate simply propofol, but they may require multimodal sedation, including but not limited to drugs such as midazolam, fentanyl, hydromorphone, morphine, dexmedetomidine, among others. And so when we look at that degree of sedation, that has a lot of demands, both metabolically and a lot of consequences potentially neurologically. When it comes to CV, this cardiovascular system, we're certainly trying to maintain stability, but in maintaining that stability, we're normally having these patients on central venous access. And when we have prolonged application of central venous access, it's quite possible these patients are more prone to have thromboembolic phenomenon associated with the catheters that they have in place. And of course, on top of that, they can end up getting bloodstream infections, more sepsis, which results in more end organ dysfunction that can have long-term ramifications. Additionally, when we look at PCILI, which is an acronym for patient self-induced lung injury, the goal is to prevent this, because when we have patients that we have COVID-19, our goal is to intubate them early and manage them aggressively so they end up not getting either PCILI or ventilator-associated or induced lung injury that we mentioned a few minutes ago. However, in situations where there's limited resources, i.e. in New York or Boston or in Georgia, where we've had really, some hospitals have had challenges making sure there's enough ventilators, we might end up having patients on BiPAP or CPAP inappropriately long from what is routinely given in terms of medical management, and then they end up having lung injury associated with de-recruitment or non-optimal PEEP settings. Nutrition is a particularly important field when it comes to, or system when it comes to the management of the critically ill patient in general, and the COVID patient in particular. It's important to remember that when patients are critically ill, they enter a more catabolic state instead of the anabolic state. So effectively, if we are not aggressively providing nutrition for these patients, then they end up digesting their own muscle, thereby inhibiting their long-term functional status. This is particularly important in the setting of disasters where there have been a substantial number of patients who have actually required critical care management, and they may have been managed by a team that was either more of a novice to having multiple patients in a disaster type setting, or they might have been very, very extended trying to make sure they could see all the patients they had in an efficient fashion. So malnutrition of critical illness can be something we see with the ramifications I've already mentioned. We did discuss a moment ago about acute kidney injury and how it's quite common in these patients. And currently right now, there is a concern about having enough hemodialysis machines to treat all these patients that actually have had acute renal failure from the acute kidney injury associated with this, similar to the ACE2 receptor agonism that we just spoke about a few minutes ago, looking at the article that described the different receptors in the different organ systems of the body. These patients commonly get nosocomial infections because they're in a hospital so long. We just saw the experience from Wuhan, China, and we noticed how those patients were regularly in the hospital for 3 weeks. We are seeing that here as well. So complicated multi-drug resistant organisms being present is something that we have to be mindful of. We found that methylprednisolone or similar steroids, while at first thought to be harmful, can be very helpful in certain circumstances with patients that end up being treated for COVID-related ARDS. And therefore, these patients can end up having long-term adrenal insufficiency because of their steroid administration that was needed during the hospitalization. Furthermore, if cardiovascular stability became an issue, then once again, they were going to require a lot of steroids to sometimes help them get off pressors, once again leading to adrenal insufficiency. Finally, early mobilization has incredible implications. There have been plenty of data indicating that even while someone's on the ventilator, if we give them physical therapy within the first 2 days of them being on the ventilator, compared to, let's say, 7 days after they've been on the ventilator, those patients are much more likely to go home and have independent functional status than patients that did not get physical therapy and have early mobilization. This mobilization also includes those patients that are prone that we talked about a few minutes ago, whether they're intubated or not. So when we look at the actual complication set that we expect from intensive care unit patients, 50% of patients that come out of the intensive care unit have some degree of neuropathy. And this neuropathy is normally diagnosed by electromyography performed by a neurologist in the clinical setting as an outpatient, or sometimes they can bring their equipment to the ICU to diagnose the patient if ventilator reading is becoming an issue or if the family requires prognostic information. In either case, neurological sequelae are very common, much frequently, or much, I want to emphasize, is very much related to the administration of neuromuscular blockers. So you can have patients that may be young, but actually relatively weak. From a psychiatric perspective, about 1/3 of patients have post-traumatic stress disorder when leaving the intensive care unit. About 28% of patients have major depressive disorders or at least symptomatology consistent with major depression upon being discharged from the ICU. And this particular sort of disease process stays in place for many years following discharge. We spoke about the importance of physical therapy a few moments ago, but we have a very significant cognitive dysfunction in ICU discharges. Nearly 75% of these patients have cognitive dysfunction upon discharge. This number does go down as the patients get farther and farther out of ICU stay, and there are some studies looking between 2 and 5 years post-discharge to further evaluate this. It is important, very important to recognize that these patients have ongoing healthcare utilization. 40% of these patients will be readmitted to hospitals for different purposes, and of course, when patients are chronically ill in this fashion, they end up requiring many surgeries pretty frequently as well. These surgeries are not necessarily limited to tracheostomies and percutaneous enterogastrostomy tubes or PEG tubes. It is also important to recognize that for the COVID patient population, anticoagulation has turned out to be extremely important, and anticoagulation is really something that we've had to be much more aggressive than we originally thought. At this point, many centers are following D-dimers, which are routinely elevated in COVID populations, and giving Lovenox at therapeutic doses even before there's a PE or a DVT. What we don't know right now is how long those patients will require Lovenox. And particularly when we see signs of DVT or PE, we want to make sure we keep them on anticoagulation. So it's quite foreseeable that a patient may come to the ambulatory surgical setting with anticoagulants on board without a specific diagnosis of a DVT or PE because of the fact that they were COVID. We don't know exactly how this is going to turn out yet, but it is something that is undergoing active discussion. Renal dysfunction has been mentioned quite a bit, and that clearly has quite a few ramifications for our patient population in the ambulatory setting. And adrenal insufficiency or the need to administer steroids to this population may be likely. And so we have to be very, very mindful of that because we don't know. I should mention that for those last three things, we don't have clear data yet from the COVID population describing that. But we'll discuss that in a little bit more in just a moment. This article from Critical Care Medicine from Desai et al. Is a very, very nice demonstration of the multiple ways that it's possible to end up having chronic dysfunction associated with ICU stays in general. Please note this article was written in 2011. It's a fantastic article, but it doesn't include anything regarding MERS, SARS, or COVID-19. Now, there are some chronic effects of ICU stay that we need to specifically mention. Chronic critical illness is a disease process that's noted in 8% of admissions in the United States to ICUs, and it's primarily associated with prolonged mechanical ventilation, 72% of these patients, and sepsis, 64% of these patients. And you can clearly see how our patients that are on the vent for 1 week, 2 weeks would clearly fall into this category. And then many of these patients, more than half of them, at 56%, have chronic comorbidities as well. And chronic critical illness is when a patient is chronically hypotensive, chronically not functional, can't ambulate, requires a skilled nursing facility or long-term acute care hospital level of care in order to be maintained. This is something we generally try to avoid, and if this was something that we saw in 8% of ICU admissions before, we can anticipate that this may go up in the COVID population. but there's no data on it yet. We don't know for sure. Also, prospective studies have indicated there's a substantial amount of fatigue in patients following ARDS. And this fatigue has occurred in nearly 50% of these patients, not only 6 months, but even 1 year following their discharge from the hospital and having a direct follow-up with a research team member. Furthermore, we have not been able to directly correlate this fatigue with neuromuscular function, such as ascendus spirometry, or whether or not someone can be extubated from an elective case earlier. But it's important to recognize these patients would not have the same strength that we would normally see. We talked about PTSD a few minutes ago. We can expect drugs associated with that. But it's important to once again emphasize we don't have a clear relationship to OR respiratory function and prolonged ARDS. We just know that symptomatology is present and we have substantial patient population, nearly 50% reporting or eliciting symptoms after discharge. This has been alluded to by my outstanding colleague a few moments ago, but recognizing that since we have such a large patient population that actually has COVID-19 in terms of the penetrance in society, we still only have conducted 3 million tests, and this testing volume will not be compatible with actually being able to screen the entire population. The most recent data from Harvard suggests that we need to have somewhere around 3 million tests available per week in order to truly penetrate the population and see what we're looking at in terms of the amount of disease present in the community. And these are the very common types of tests that are available: the GenExpert test from Cepheid, the Panther Fusion test, the one that the president actually emphasized quite a bit, which is the ID Now from Abbott Pharmaceuticals, as well as Roche Labs has a SARS-CoV-2 test as well. And all of our hospitals have different degrees of tests, different testing availability. But I think this diagram here shows the incredible plurality of tests that are currently available. And most of them are nucleic acid amplification tests. This is important because when we compare this to, for example, our seasonal influenza test or things of that nature, malaria tests, those are not nucleic acid amplification tests, but those are more antigen identification tests. So really, even our Abbott Diagnostics rapid assay, which is available in 15 minutes, is still a nucleic acid amplification test. We still don't have absolutely clear data as to the sensitivity and specificity of these, and particularly with the number of vendors involved in this, it can depend on the facility that's involved. So how do we actually calibrate for that? Well, here's a local testing example. We have at Herman Hospital, which is one of the hospitals I practice in, we looked at comparing the Abbott to the RT-PCR that LabCorp actually provides. And there's a 98.7% concordance, which yielded, if we consider the LabCorp gold standard, a 97% specificity and a 17% sensitivity, or similarly a positive predictive value of 84% or negative predictive value of 94%. These numbers are not actually perfect and will still require us to perform multiple tests in order to verify a patient doesn't have coronavirus. And when we look at swabs that go to nasopharynx or oropharynx compared to tracheal aspirates, those don't seem to be different. But we've had negative tests that eventually a patient shows symptoms of fever, sore throat, cough, dyspnea, everything you see right here. And anosmia is the lack of smell, and dysgeusia is the lack of taste. That eventually we had to retest again and then find out they actually had COVID. So even when we have a robust testing infrastructure, we're effectively looking at a situation to where a positive test is helpful, but a negative test doesn't truly rule that out. So even if we have that in an ambulatory surgical setting, that could be problematic. And when we look at ambulatory surgical settings, there's really going to be the issues of vector control. So when we look at an anesthesia machine, one thing that's important to keep in place is our N100 filters, or the same filters we talk about using when we actually need to repurpose an anesthesia machine for utilization as an ICU ventilator. We want to make sure the machine does not become a nidus for infecting other people for such a highly transmissible disease. Furthermore, we look at the types of cases that are performed in ASCs. For example, there's a paper here written by Dexter et al. Looking at the NACOR database, finding that 15% of daytime surgeries are upper GI endoscopies or upper abdominal and lower abdominal laparoscopies. So 30% of the population that may end up coming to an ASC will be a patient population where you're going to have insufflation under 10 millimeters of mercury or so pressure from an endoscope from a gastroenterologist, or laparoscopic insufflation, which has still been concerning for potentially spreading COVID disease. Airway management has been a very, very important topic when it comes to management or measurement, prevention of disease in terms of spreading COVID in the ambulatory setting, as well as the inpatient setting. And so we're still going to have to make sure there are clear techniques for these patients. Regional anesthesia has been advocated for those who want to minimize airway management, but in the ambulatory setting, regional anesthesia is a relatively maximized modality and should consistently still be part of the armamentarium. Once again, likely having the need for steroid administration for patients that you know had a prolonged critical illness course of COVID-19 would be important. And elective surgeries with COVID can be quite concerning. Once again, there's limited data, but we do have some data from Wuhan, China, written by Li et al., where they looked at cases, all cases that occurred in the hospital between January 1st and February 5th. There were a total of 34 patients that had surgeries, and they were asymptomatic when the case started. But all these patients were eventually found to have COVID. So they really locked into this patient population that had COVID found after the elective surgery population. 100% of these patients ended up getting pneumonia. And 44.1% of these patients required ICU admission, with 20.5% of them dying. So that means in the ambulatory surgical setting in Wuhan that went on to elective surgeries, they had a mortality rate of 20% across the board. And these were cases that were elective in a hospital. So they included pancreaduodenectomies, esophagectomies, thoracic lobectomies, radical resection of rectal cancer, and a couple of types of orthopedic surgeries. But just to illustrate the point that this sort of disease can be very, very problematic. And this is the kind of pattern that they saw. They admitted the patient, conducted surgery sometime within the first 5 days, and the first sign of clinical symptom occurred after that 5 days. And then between that 5 and 9.5 days where we had that sign of symptom, once again, just like the rest of the experience in Wuhan, dyspnea followed by ARDS, and for those that died, death. Once again, with a prolonged clinical course at 21 days. So when we look at preoperative considerations in this patient population, ACE inhibitors, as has already been mentioned by my esteemed colleague, are not really something we want to try to deliberately give or deliberately hold. We don't know the actual interaction with ACE inhibitors. We have this outstanding report from New England Journal of Medicine, which looked at the postulated mechanisms of how the angiotensin II receptor can interact with the angiotensin I and angiotensin II molecules in the setting of ACE2 regulation or modulation in the setting of COVID. But right now, we think the risks are much higher to stop ACE inhibitors. And so we would treat these patients like we would in any other ambulatory setting. We're going to have them stop because it's unsafe, because of volatile anesthetics. We continue to do that. We really should avoid NSAIDs. There's no clear data on this. But there was a report that came out from the Minister of Health from France, which is a letter that was published. And so based off of that, we really recommended avoiding NSAIDs. We do not know how long after COVID infection these NSAIDs should be avoided, but this would automatically include drugs such as ketorolac. Immune function pre and post-operatively should be considered. And when we're talking about immune function, there's also procedures that also, for example, inhibit the endocrine system that cause hypothyroidism, for example. There was an interesting case report in neurosurgery from 2020 where they really attributed someone after endoscopic pituitary adenoma resection to actually have increased complexity because of their hypothyroidism. And prophylaxis has no role. So we really don't have any active discussion about administering hydroxychloroquine or zithromycin. The data in this is really not clear. In the original study that showed hydroxychloroquine being beneficial was actually, it wasn't retracted, but the governing organization that manages that journal stated publicly that after further review, they did not feel that article met their publication standards. So in summary, testing is going to be very key to any ambulatory setting for it to be safe. And that test is going to be a lot better than it is right now. And we're going to have to make sure that we have the appropriate modalities to do that well. Multi-organ failure can have long-term ramifications. We're still measuring that. Many of these patients are still in the hospital, so we don't know what that will actually be. But we know that COVID-19 is particularly harmful in the perioperative setting, and every effort should be made to screen those patients. Long-term effects are still under investigation. Remember, we can serve as vectors for infection with COVID if we're not careful. And with that, I want to thank you very much for your attention. I'm happy to yield the floor back to President Abdelmalek.
Thank you very much to Dr. Mossad and Dr. Williams for very informative talks. I believe you helped us to accomplish our goals from this webinar covering COVID from A to Z and beyond that, where we expect to start seeing some of these patients in our operating room and hopefully in our ASCs. And you told us a few things that we need to look for and watch for. With that, I received a couple of questions. First one is for Dr. Mossad. What is the rationale behind the loss of smell and sensation? I guess that was the question. I'm not sure what they meant by and sensation, but what is the rationale behind the loss of smell and probably taste? I heard somebody lose taste.
Yeah, probably smell and taste.
Yeah.
I don't know. In fact, we don't know that this is actually true. It's a perception. I'm not aware that it has been objectively studied, and the one publication that I shared was really clearly stated that was not peer-reviewed and yet to be verified. So we don't really know for a fact that this is the case, and how it happens, I really would not know.
Thank you, Dr. Mossad. Dr. Williams, I have a question for you from our audience. Say, intubation, mechanical ventilation, do you think they have a role in accelerating the progress of the disease in the more debilitated patient population?
That's a fantastic question, and that is something we're discussing a lot. There is a feeling that our traditional mechanical ventilation approach may be more harmful in COVID patients. However, similarly, we found that when we have delayed intubation in these patients, they've clearly done much worse in the critical care environment. We think there's probably some pathophysiology that we need to further identify. Hopefully, with assistance from the research of fantastic individuals like Dr. Mossad, we can identify that. But right now, we do feel that external positive pressure ventilation or non-invasive ventilation does not have an ideal role in the management of COVID-19 patients. They should be intubated.
Thank you. Well, I don't think we're going to do esophagectomies or any of such operation in our ASCs. Many of our members are still concerned about performing any surgery in COVID positive, as well as exposure to patients. So many societies, including ours, advocate for testing before elective surgery, if feasible, especially in the areas that are heavy hit with infection and higher prevalence of the disease. We're just wondering if you tell us what testing means and what kind of test you would recommend for us. Like, let's start something that I know we're not going to use, but I just want to get that out. The immunity testing, IgM. What does it mean, Dr. Mossad?
Thank you. Yeah, that's a question on everyone's mind.
Okay.
So serology is, in a nutshell, not ready for prime time. So it's not ready for diagnosis of acute illness, not ready for diagnosis of long-term immunity, and it's not even used for the plasma donors, the recovered people from COVID-19 who are donating their plasma. They're not testing their plasma to assess how much antibodies are in it because the test is inaccurate, so they can't decide on it. They just take people who are sick and recovered, so they presume that they have something in their plasma that would be protective. So at this moment, it is not a test to use for risk stratification, diagnosis, recovery, or safety for performing procedures.
Testing for the virus. What is the fastest one? How long will it take? So as folks can time the timing of the testing before the surgery as patient come into ASCs.
Sure. I mean, we deal with this currently, for example, in the people who come in for a transplant, and because the organs are available and should be viable in a certain number of hours, so they do the fast track testing, and that, in essence, the test itself could take less than half an hour, but just to get it, from the person to the lab to process to be reported, it takes about a couple of hours, and that's what's called the fast track testing. Our standard testing, at least in Cleveland Clinic, is turnaround is about 24 hours.
Thank you. Dr. Williams, I have a couple of questions for you. Would you suggest delaying surgery in ambulatory surgery center for perhaps 6 months after COVID plus ICU stay?
Oh, that's a great question. So when it comes to the degree of dysfunction and the frequency that we see in organ disease, hypercoagulability, if the patient is not going to be harmed by delaying the surgery, i.e. if it's not a cancer surgery or something that will cause loss of life in the limb, ideally these patients should get an opportunity to regain normal end organ function. We see in almost all these studies looking at how these patients do across the board before we even have COVID, it really takes about 6 months to really start having more functional status, more normal end organ function. We don't anticipate that'll be different or faster with COVID. So 6 months to a year would be, in my mind, an ideal way to make sure we're minimizing the potential for harming these patients because of the actual type of surgery they're getting.
Thank you. Another question for you from our audience. How different is COVID lung injury in comparison to standard ARDS, please?
Fantastic question. COVID lung injury is uniquely inflammatory. It's clear it is a profound sort of hypoxia that seems much out of proportion to what you'd expect for when you look at a patient, look at their parenchyma at baseline. They come in immediately with this bilateral patchy infiltrate, and they're hypoxic in a way that's refractory to everything that we do. So from my perspective, these COVID patients, ARDS is a lot more of a bigger, fatter, meaner kind of ARDS than traditional ARDS that we tend to see. So from that perspective, the management has been relatively unique, and we actually are using different ventilator modes and, in fact, much simpler ventilator modes than we would normally use in regular ARDS. So they're clearly different animals and have to be treated differently.
We passed our time, but I received another question from one of our audience as well. Maybe you can take a minute to answer that. It says, would airway instrumentation provoke virus activity in asymptomatic patient by itself?
I'm happy to take that one. There's no indication we have that the actual act of instrumenting the airway promotes viral activity. The asymptomatic spread versus the symptomatic phase versus the convalescent phase appears to be completely the same. We don't have any data to suggest that that is different. It should be noted, though, that airway instrumentation does promote droplet formation. So if you're concerned about that or you have any risk factors for the disease in terms of the patient, you should be taking protection for yourself, because those droplets can be easily spread because of the fact you're manipulating the airway.
Thanks, Sharif. Thank you, George. You guys have been phenomenal. You give us a lot of information to consider and think about. And for all the audience out there, thank you for joining us tonight. Please remember to mark your calendar for next week COVID webinar talking about the roadmap for reopening your closed ASC and resume elective surgery. And also, please consider joining us for SAMBA 2020, a virtual experience. I promise you something that you will not regret doing. With that, we'll conclude tonight's webinar. Thank you all. Have a good night.
Thank you.
Be safe. Stay well. Take care. Good night,
Thank you.
everyone.
Good night. Good night. Bye-bye.